the New Jersey Center for Tourette Syndrome and Associated Disorders. Its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introductions of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Thanks, Kelly, and good evening, everyone. Welcome to tonight's webinar. Our Wednesday webinar series took a brief hiatus in July, so tonight's webinar is our first for this school year, and it's on one of the most requested topics we have ever had, dyslexia. Before I introduce tonight's presenter, I would like to call your attention to the slide on your screen announcing our next Walk for TS, which will be in Medford Lakes, New Jersey on Sunday, September 18th, beginning at 8:30 a.m. If you cannot attend, we hope that you will please go to our website and make a donation in support of the services we provide for families living with Tourette. The proceeds from the walk will support our educational outreach programs. For the educators in our audience, we will be presenting a workshop at the NJEA convention in Atlantic City on November 11th at 3 p.m. The topic will be TS, OCD, ADHD, strategies and accommodations for diverse learners. Now to the introduction of tonight's presenter, Dr. Michelle Humm. Dr. Humm is a licensed clinical psychologist and a formally trained pediatric neuropsychologist with over a decade of experience conducting evaluations of children and adolescents with acquired or developmental neurocognitive disorders. She received her undergraduate degree from Haverford College in Haverford, Pennsylvania, and her PhD in child clinical psychology and developmental cognitive neuroscience at the University of Denver, and an internship in pediatric neuropsychology at Children's Hospital, Colorado. She completed a fellowship in pediatric neuropsychology at the University of Illinois Medical Center for Cognitive Medicine. Dr. Humm currently is a neuropsychologist at the Center for Neurological and Neurodevelopmental Health in Wall Township, New Jersey, where she sees patients with dyslexia and other learning disabilities, including ADHD, autism spectrum disorders, developmental delays, and other neurodevelopmental disorders. She studies the long-term outcomes of children exposed to substances in utero, traumatic brain injuries, epilepsy, and the effects of neurological diseases on cognitive functioning and learning. Dr. Humm, welcome. We are so pleased to have you join our webinar family. And now, without further introduction, I'm happy to turn tonight's presentation over to you.
Your slides are up and visible.
Oh, perfect. Okay. Well, thank you so much for that introduction and for having me. Tonight I'm going to be discussing dyslexia, which is something that I have been involved with for many years from a research perspective and from a clinical perspective. So we're going to be talking about dyslexia and what we can do to help children who are identified with that disorder. So here's an outline of what I'll be talking about. So I'm going to be talking about what is developmental dyslexia. And I should note here that I'm not going to be talking about acquired forms of dyslexia from a brain injury or a stroke, etc. I'm going to be talking about the developmental form of dyslexia. I'm also going to talk about what dyslexia is not and some common misconceptions about dyslexia. I'll talk about the conditions that are commonly associated with dyslexia. We're going to talk about etiological factors, what causes dyslexia. We're going to talk about what you look for in an evaluation or an assessment of dyslexia. We're going to talk a little bit about treatment and then outcomes for individuals with dyslexia. So first we'll talk about what is dyslexia. So developmental dyslexia is a failure to make expected progress in learning to read, or unexpected poor reading. It was first recognized or discussed in the late 19th century by a British physician, Dr. Pringle Morgan, who identified and described it in a 14-year-old boy with average intellectual functioning, good eyesight, and appropriate years of instruction who just couldn't learn how to read. And he noted that there were similarities between this child and other adults he had treated who had acquired reading difficulties after a stroke, and at the time that was called word blindness. So he started calling this congenital word blindness. Over time and with more research, it became known as developmental alexia and then eventually developmental dyslexia. So what dyslexia is not? We're going to start there. Dyslexia is not a visual problem, and that's one of the misconceptions that has been around for many, many years, and it's based on early theories from the 1920s and research around that time that focused on the visual, perceived visual errors. So individuals might decode a word and say be instead of D, or was instead of saw. And those theories focused on dominance in the brain. So they thought that one side of the brain was not suppressing the other side of the brain, and so there were mirror images showing up. And so the focus was on this visual explanation. So people were prescribing eye training programs and all kinds of visual interventions. Over time, it was determined there were really no evidence for these. They weren't helping individuals learn how to read. And research was focusing on why that was the case. Later research in the 70s identified that those letter reversal errors were only made in an individual's own language. Obviously, that they couldn't be visual because you'd see it in all kinds of visual stimuli, including letters from other languages, etc. And it was only specifically focused on an individual's language. So it has to be a linguistic deficit. And subsequent research over time has shown that individuals with dyslexia aren't particularly prone to reversing letters or words, although you do see that it's not a universal feature in dyslexia, and that we believe that it's much more related to the language system. So their research now has focused on dyslexia as being a primary deficit in phonological processing, which we identify as a language-based learning disability. Individuals, as I said, don't read backwards, and letter reversals may or may not be present. The International Dyslexia Association has come up with a definition. So we know that it's a subject-specific learning disability. We know it's neurobiological in origin, and it's characterized by difficulties with accurate and or fluent, which is fast, rapid, word recognition, and by poor smelling and decoding. So like I said, it's a deficit in the phonological component of language, understanding how words break up into their component sounds, and it's unexpected in relationship to the other cognitive abilities. And of course, they had to have had effective classroom instruction and be failing even in the context of classroom instruction where other kids are successful. Now, secondary consequences include problems with reading comprehension and reduced reading experience over time. So eventually, individuals may have a limited vocabulary and background knowledge because they're not reading. When we think about dyslexia, we want to look at the early risk factors. So very early on, some individuals have difficulty learning to speak, or they have delayed language development. Ongoing language problems with both expressive and receptive, or one or the other, so their vocabulary development is more limited than others. They struggle with listening, following directions. Learning letters and their sounds. So once they're exposed to letters, potentially in preschool or kindergarten, they have difficulty in learning the letters' names, and then when they have to learn that B makes the B sound and D makes the D sound, they struggle with learning those skills. They have difficulty recognizing rhyming patterns. So for individuals who are of preschool age, you see a lot of nursery rhymes and songs and books that have rhyming patterns, and most kids pick up on these very, very easily. And individuals who are at risk for dyslexia and will go on to develop dyslexia often have more difficulty identifying those patterns. They also have difficulty learning other rote skills, learning the names of colors, the names of shapes, etc. And they often have lasting problems with articulation. It's difficult for them to blend sounds together as well. So when you see that cluster of risk factors, you want to be on the lookout for dyslexia. In primary grades, you have ongoing issues with rhyming. They struggle with counting syllables in words. They have difficulty making words come apart. So in first grade, they're often asked to say, what are the sounds in the word cat? And they're supposed to be able to say at. Well, individuals with dyslexia or who are at risk for dyslexia at that point have difficulty identifying that. They might substitute an unrelated word when they're supposed to be reading. They see a picture of a dog in a book and they say puppy as opposed to trying to sound out the word dog. They might make whole word guesses. So for example, if you see the word depend, they might not have any idea how to sound that out, so they say deepen or dispose, something that might look a little bit visually similar, but they're not taking the time to decode all of the sounds in that word. They might make mistakes on little words like the, of, or on words that can't be sounded out. When they encounter an unfamiliar word, they might have no idea how to go about reading it, and again, they might make a whole word guess on that. Difficulty learning the rules for spelling. They might spell words the way they sound or use a letter name in the middle of a word. And in many cases, an individual's listening comprehension is better than their reading comprehension. They can listen to someone tell them about something and take in information that way, but when you ask them to read it, they're focusing so hard on the decoding that they struggle with the comprehension. In older elementary school, middle school, high school, and beyond, they remain reluctant readers. They don't want to read out loud. They don't read for fun or pleasure. They're slow words, disfluent. They're slow readers and disfluent readers. They have difficulty reading words that are not in their vocabulary. Very poor spellers, though, so that is one of those lasting issues that you often see. Writing is affected as well, so they're slow, it's effortful, they tire easily, they say they don't want to do it, and their writing often does not reflect their knowledge. They might substitute another word that sounds the same when they're reading. They might mispronounce long, unfamiliar words. They might have, like I said, reduced vocabulary knowledge and use filler words like or thing as opposed to using a precise vocabulary word. Then there are other related academic problems. Organization of their written language can be hard. They might have difficulty memorizing rote information. So many individuals, it's very difficult for them to memorize a list of items for a test. They might have difficulty persisting with and reading longer assignments, even if they can decode and eventually learn to decode. It's so effortful that it's hard for them to persist with that. Learning a foreign language is often very, very difficult. There's, if you think about it, if the primary difficulty is learning the letters and their sounds, then if you give them a whole new set of letters and sounds to learn, of course that's going to be very difficult for them. And math operations and problem solving can be difficult as well. I should note that not all students who have difficulties with these skills have dyslexia and vice versa. That's why individualized evaluations are important to identify what strengths and weaknesses that individual child has. How widespread is dyslexia? So dyslexia is one of the most common learning disabilities and developmental disabilities. So depending on the research study you consult and depending on how they define dyslexia, up to 1 in 5 people have dyslexia, at least in one form. Dyslexia affects people from different ethnic and socioeconomic backgrounds nearly equally. So it is widespread across the socioeconomic spectrum. There are a number of myths that persist about dyslexia. In the past, individuals thought that dyslexia only affected boys. We now know that that's not true. The exact gender balance is unknown. Some research indicates that it's nearly 50-50, and some research indicates that there's a slight preponderance for boys rather relative to girls, but they're definitely girls with dyslexia, and we should definitely focus on the fact that it could be present in any child that we see. It's important to note that individuals with dyslexia can be very, very bright. So there's many individuals, when they struggle with learning to read, they think they're stupid because they can't do this thing that comes easily to other people. And it's absolutely not the case. And in many cases, you can be gifted in all other aspects of your cognitive profile, but struggle with this one very specific aspect of language processing that makes it difficult for you to learn how to read. And I just saw a child who fits that profile exactly. He was an 8-year-old child, very, very bright, gifted in terms of his verbal reasoning, very knowledgeable about animals and nature, can tell you all kinds of things about the things that he's interested in, with a great vocabulary, very pleasant to be around. But if you give him a passage to read about that particular topic, he really struggled. And again, if you ask him comprehension questions that he has to read, he might not be able to tell you or show his knowledge about that topic because it's very difficult for him to read and comprehend. Another myth is if you do well in school, you can't be dyslexic. And I can't tell you how many kids I see who struggle and struggle and struggle and work very, very hard, work hours and hours and hours every night on their homework, and put in lots and lots of effort, and their grades are pretty reasonably good. That doesn't mean that they don't have dyslexia because they're struggling and are working so hard to overcome and compensate for this weakness. Some people think individuals with dyslexia won't learn to read, and that's not true either. Learning how to decode words will come for most people, assuming the rest of your developmental profile is intact and you're not globally delayed. Most individuals with dyslexia will learn to read. It just is a matter of how quickly they read, how effortful it is for them in the long run. Laziness is another topic. Some people think, oh, they're just being lazy. Well, that is absolutely not true. Like I said, the majority of kids that I see with dyslexia work extremely hard and much harder than their non-dyslexic peers. So can't obviously be due to laziness. There's other folks that also seem to be lazy because they won't try to sound something out, but it's not because they're lazy. It's because they really don't have the strategy and don't know what to do. So if you see that and you think it's laziness, it probably is worth checking out. And other research in the past suggested that maybe kids grow out of it. By the time they're teenagers and adults, they no longer have dyslexia. And that's not true either. We do know that dyslexia is a lifelong learning disability. It just looks different at different stages of development. So they might learn how to read, but again, they might be dysfluent readers, slow readers. They might struggle with spelling over time. They may need extra time to get through things as a young adult in their jobs, for example, but they still struggle with many of the same issues. So now we're going to talk about some of the things you commonly see associated with dyslexia. So the first one and the most common one is dysgraphia. Dysgraphia is unexpected difficulty with written expression. So they might struggle with handwriting, spelling, both in kind of a single word spelling manner as well as in sentences and paragraphs. They might have messy and disorganized papers, difficulty copying from the board, difficulty with fine motor skills, more globally, and problems remembering motor movements to form the letters. So if you see any of those things, you might have dysgraphia along with dyslexia. Dyscalculia is another learning disability, which is unexpected difficulty with math. It's less commonly associated with dyslexia, but there are individuals that have broad-based learning issues, and they may have a primary difficulty with dyslexia, but also struggle with math. They might have difficulty, people with dyscalculia might have difficulty counting correctly, might misread numbers, they might have difficulty memorizing math facts, might have difficulty copying math problems, organizing their work, make calculation errors, or retaining math vocabulary concepts. Other individuals with dyslexia have broad language impairment, and you see a wide range of kind of language abilities in individuals with dyslexia. So some folks, like this child I mentioned earlier, has really gifted in terms of his language abilities and his abstract verbal reasoning, and some folks have lifelong impairment or delays in their language relative to some of their other skills. So they might have difficulty, if they have broader language impairments, in acquiring structural language, understanding word parts that mark meaning, mastering grammar, understanding syntax, so the structure for ordering words, finding their words in memory, retrieving words, making inferences that go beyond what's stated in the text. So there are some, broader issues in places where the language impairment impacts their learning beyond dyslexia. And again, their vocabulary development might be more limited. Many individuals with dyslexia early on in their development, before reading even becomes a factor, may present with speech sound disorder. So that's unexpected difficulty with accurately producing speech sounds. Now, some individuals may struggle with auditory discrimination, actually hearing the different sounds, and that would definitely put you at risk for phonological problems once you're trying to learn how to read. Others have speech sound disorder from a motor perspective, which is less directly related to dyslexia. But if you see articulation difficulties in a young child, that's also a red flag to watch for their reading development. ADHD is also very commonly associated with dyslexia. So as you know, individuals with ADHD could have an attention disorganization, they could have hyperactivity or impulsivity, or they could have both. And many individuals also have poor executive functioning, losing things, poor sense of time, etc. ADHD is one of the most common developmental problems. It affects 3 to 5% of the school population, and it's estimated that up to 30% of individuals with dyslexia have coexisting ADHD. Now, for those folks, it's the inattention symptoms that really overlap with ADHD. So individuals with dyslexia are more likely to have attentional problems, and that puts them at risk for ADHD. Then there's mental health issues that are associated with dyslexia. Emotional difficulties. If you think about school being your job as a child, and you're not very good at your job because it's really difficult for you to learn the primary thing, the main thing that all the kids are learning seemingly easily, that causes stress, it causes anxiety, it could make someone have self-esteem issues, depression. And in general, these emotional difficulties are believed to be secondary to dyslexia, a consequence of having so much difficulty learning. Other individuals show behavioral difficulties, oppositional behavior and conduct. Now there's some folks who show these behavioral difficulties before the onset of reading instruction, before they show signs of reading difficulty, and that could be due to comorbid ADHD. So it's more of a primary problem, or it could be a secondary problem. There's folks who have behavioral difficulties because they're embarrassed to read out loud, so they'd rather act like a class clown and not listen to the teacher rather than being forced to read out loud in the class. So we're going to talk a little bit about some of the causes of dyslexia, and we can look at that from different levels of analysis. So first, from a genetic level, and I'm going to talk about these in really broad strokes, but I can potentially answer questions or direct folks to more information afterwards if they are interested. So from a genetics perspective, we have seen for years that there are reports of reading and spelling difficulties across generations in the family, and many times parents with dyslexia have children with dyslexia. So I ask very frequently when I'm taking a family history if anyone else in the family has any problems or spelling problems as a young child, and almost inevitably one of the parents does, or an uncle does, or someone in the family has issues, similar issues to the child. What we know from behavioral genetics research is up to 80% of the incidence of dyslexia is genetically related. And many of the genes actually code for neuronal migration, meaning they tell one neuron where to go in brain development, and that may be related to some of the primary neurobiological problems in dyslexia. without getting into too much specifics, we do have consistent linkage findings in certain chromosome regions, and there's 4 candidate genes for dyslexia. And these are pretty well replicated, so we know a lot relative to other neurodevelopmental disorders about the genetics of dyslexia. We can also look at the level of the brain in terms of causation for dyslexia. So what we know is that there's no single location in the brain which serves as a reading center. Reading is a cultural phenomenon, so there's no reading part of the brain. But everybody learns language, everybody across the world develops language, and so we do have regions in the brain that are specific for language. And what we know is that the language regions of the brain also are the reading areas of the brain. So in the left hemisphere, there's a network of different parts of the brain that do different things in terms of reading. So there's a visual area in the back part of the brain that identifies the letter and the word. There is a region in kind of the middle area of the brain that analyzes the word, gives it meaning, and then in the more frontal part of the brain, that area is responsible for articulating the word, sounding it out, and decoding. And we know that the activation in these different brain regions is different in individuals with dyslexia. We also know that the connections between those brain regions are different in individuals with dyslexia. So we do know from a neurobiological perspective, there are pretty clear signs that individuals with dyslexia have differences in the way their brain work. And interestingly, after intervention, they look more like non-impaired individuals in terms of their brain activation. There's also differences in brain chemistry. So we know that there are certain brain metabolites that allow neurons or nerve cells to communicate with one another. And there's several of these metabolites that are different in individuals with dyslexia. So folks with higher concentrations of two metabolites, choline and glutamate, were associated with poor reading performance. And these are also related to what we call white matter anomalies, or the parts of the brain that connect these regions of the brain. So again, it all kind of hangs together. Then there's lots of folks who look from a neuropsychological or neurocognitive perspective to determine what kind of neurocognitive signature dyslexia shows. Like I said, we talked about phonological processing, difficulty breaking down words into their component parts. We talked about broader language issues already. So I'll spend a little more time on processing speed. Individuals with dyslexia take longer to process information than their peers. From a neurocognitive perspective, that's related to some of the brain findings because these white matter anomalies may be associated with how quickly they can process information. So we know that individuals process language-based information more slowly. If they're asked to rapidly read words, they are slower at that. If we ask them to rapidly identify different colors, they're slower at that. Rapidly name objects, they're slower at that. But it's also related to non-language based or visual processing. So they're also slower at doing speeded visual tasks. So in general, their brains are a little bit less efficient, a little bit less quick. Many individuals also have difficulty with what we call working memory. Working memory allows us to do mental math or memorize a phone number in order to call somebody. You don't need that information for a very long time. You only need it to stay in your memory for a very short period of time. We know that individuals with dyslexia have a hard time with working memory. Individuals with dyslexia also have difficulty with attention. Now, in some ways that's related to comorbid ADHD, but even if they don't have ADHD, there are subtle attentional findings in individuals with dyslexia, so they're not as good as non-dyslexic peers, oftentimes at attention tasks. Then what we call executive functioning, so organizational skills, planning ahead, making sure that you know where all your papers are, that can be more difficult with, for individuals with dyslexia. Then there's other folks who have looked at kind of lower level sensory motor issues, auditory processing, visual processing, tactile processing. So in some folks, not everybody, there could be kind of a broader sensory issue. I'm going to talk more about the assessment and evaluation of dyslexia. So why is a formal evaluation important? Well, it's really important to establish the correct diagnosis. And I just saw a child today that really underscores this point. So he's 13 years old, and for all of the years of his life, the focus has been on his ADHD symptoms. And everybody has identified that he's inattentive, that he's hyperactive, that he's impulsive, and have tried to remediate those symptoms. Everybody knew he wasn't very good in school, wasn't very successful, was really struggling, but they assumed it was secondary to the ADHD, and he'd never had a formal evaluation. Even though he was particularly weak in language arts, and they knew that that was something he didn't really like and didn't read for pleasure. You know, he had all of these signs, but everybody thought, well, that's because he has ADHD and he just can't attend and he can't stick with things. Well, I just evaluated him today, and as a 13-year-old child, his reading is at a first, second grade level. His phonological processing is at an early first grade level. He really is struggling with these basic dyslexia-specific issues, and he clearly has dyslexia. And in fact, his dyslexia is much more severe than his ADHD. If you test his ADHD, it's much milder. So he really has a primary diagnosis of dyslexia and a kind of secondary diagnosis of ADHD. So it's important to establish the correct diagnosis so we can intervene correctly for these individuals. It's also important to get targeted or individualized intervention planning that's specific to the child and their unique needs. So there may be children who are slow at processing information. We need to give them extra time. There may be other folks with terrible working memory and organizational skills. We need to support those skills. There may be folks with comorbid dysgraphia and related fine motor issues. We need to support them there. So we need to really know a lot about where they are in multiple domains. We also need to know exactly where their reading skills are so that we can intervene there. I've seen individuals who are in 5th or 6th grade, and they are getting extra help, but the extra help is being given kind of closer or targeting reading at a 4th grade level, you know, one reading level back. And really, they need someone to start with them at a kindergarten level or 1st grade level and intervene at that level. Then also, you know, we need to address a child's specific neurocognitive comorbidities. If they have comorbid ADHD, we need to address that, etc. This also serves as documentation. So the earlier you start documenting that these issues are there and the kind of accommodations that are helpful, the better it is in the long run for these children to get accommodations later on in their development. So an evaluation for dyslexia should always be individual. And there's a number of different clinicians who could provide this type of evaluation. So lots of master's level clinicians and lots of different areas of expertise. It is not necessary to have a medical evaluation like by a neurologist, and it's not necessary to have a neuropsychological evaluation. Although, of course, as a neuropsychologist, I think it's very helpful to have a neuropsychological evaluation. I think that you can get a lot of information about a child that you might not get from a more focused educational evaluation, but it's not necessary. So what to expect? So in a clinical interview, the clinician should gather information about a child's birth history, family history, a child's development, their early speech and language development, and review all of their records, grades, previous evaluations, any treatments they've had and whether they were effective. Some individuals test a child all in one day, have a big long testing session that is done all in one day. Others split testing sessions up into multiple days. Where we are at CNNH, we split into 2 different testing sessions that are 3 hours each. And that allows us to not overly fatigue the child, but it's less disruptive to a child's life and to a parent's life if we split it into just 2 sessions as opposed to more sessions than that. And then everybody should expect to receive a written report. There are individuals that don't provide a written report, but a written report is important for this documentation, and it should include standard scores and percentiles. And I have seen plenty of reports that don't. So that should be, it should have a specific diagnosis of dyslexia. It should have specific standard scores and percentiles. and should be very specific about the other diagnostic factors and treatment recommendations. So what is evaluated? Reading skills are obviously evaluated. It's really important to evaluate an individual's ability to read real words. It's also very important to identify how well they read nonsense words, how well they decode those. That skill in and of itself will tell us how well they have learned their letter-sound correspondence rules. I like to also do that speeded. So I like to do untimed single word reading, nonsense word decoding, and then speeded single word reading and nonsense word decoding, because that gives you a lot of information about how automatic that information is for that individual. Many kids can test in the average range when they're not timed, and when they are timed, you realize exactly how much they're struggling. And then it's really important to test their reading fluency for connected text. Have them read a paragraph out loud, try to see what their pace is like, how accurate they are, because as we know, it's really the goal of reading is really to comprehend what you read and learn things from what you read. And so if you read too slowly and too effortfully, your comprehension is often impaired. Phonological processing, like I said, is the fundamental problem in dyslexia, so that should be a part of every evaluation for dyslexia. So for example, you might ask someone to say cup without saying the K, or blend these sounds into a word, app. Ask them what's the second sound in the word train, for example, and you do that with real and nonsense words. That really gives you a sense of whether they can break down words into their phonemes. Phonological memory is important. Can they repeat increasingly lengthy lists of digits? How much information can they hold in their immediate memory? Can they repeat nonsense words? And then how quickly, again, do they name objects, colors, digits, letters, etc., their automaticity? It's important to know something about their expressive and receptive language. So as a neuropsychologist, I always at least have a sense of their receptive vocabulary, receptive language or ability to follow oral instructions, their vocabulary knowledge or naming skills, and then how they express themselves verbally. And if there's a problem there, of course, I refer to a speech and language pathologist for more comprehensive language testing, but at least we can get a sense of where they are from a language perspective and whether that's, and where they are in terms of their language, their broader language. Obviously, we want to look at their written language. Spelling is critically important. You look for dysphonetic spelling errors. So I like to see the word mother. I love to see how kids spell the word mother because that's a word that they've encountered many, many times in lots and lots of children's books and children's literature. And there are still kids that really struggle with trying to write that word and spell it without any clue of kind of the phonological component. Then you want to look at where they are from a writing perspective. They're writing at a sentence level and a paragraph level, and not just their overall score in terms of the writing mechanics and their syntax and semantics, but you also want to look at how effortful writing is for them. So there's plenty of kids that can score in the average range, but when you watch them, they complain, they avoid, they struggle, they complain of being tired, they fatigue easily. So how effortful writing is important to note. Math is not critical for a diagnosis of dyslexia. You don't have to evaluate math, but as a part of a comprehensive evaluation, you do want to take a look at where their math skills are. I like to look at their untimed math, whether they can solve math problems, their math reasoning, and this is with the math word problems read aloud. So it takes the reading component out, but can they set up a problem? Do they know what to do? And then their fluency for very basic math facts, how quickly they can do basic math facts. Many kids with have adequate math calculation skills and even math reasoning skills when it's accommodated or read aloud, but they have poor math fluency due to this automaticity issue. Then there's other folks that struggle with mathematical language and have problems with math word problems because they can't figure out how to set up the problem. Sometimes that's related to a broader language issue, but that's specific to the child. Intelligence testing can be a very helpful addition to one of these evaluations. Again, it's not critical. It used to be required because in the past we had a requirement to have an IQ and performance split in order to make a diagnosis of a learning disability like dyslexia. Now it's no longer required. But again, it's still important. We want to know if individuals have a split because that will tell us a lot. If an individual is testing kind of in the low average range for reading, but they're gifted in terms of their visual spatial skills or their verbal abstract reasoning, that's really important for treatment. You'd want to identify these strengths and weaknesses. You want IQ tests to evaluate working memory and processing speed, so you'd want to give an IQ test to get information about that, and then that'll help you design a targeted intervention program. While many of the interventions are similar for someone on the low end of the IQ spectrum and the high end of the IQ spectrum, you might expect kids to respond differently to them if they're very high functioning versus lower functioning. Now, again, like I said, I think the neuropsychological assessment is important and will give you a lot of information. Again, like I've talked about, we would evaluate intellectual functioning, attention and working memory to see if, even if they don't have ADHD, are there problems with basic attention and how quickly they process information. But a neuropsychologist will also take an in-depth look at learning and memory. And there's a few things I like to really understand about learning and memory. I like to see if there's a particular type of information or modality they learn better in. Do they learn better with visual or auditory information? Do they learn better with rote information or meaningful information? And how do they respond to repetition of information? Meaning, maybe they struggle when you first read them a list, but after 5 repetitions of the list, they really have it down and they remember it after a delay. So you'd only get that by really comprehensively testing their memory. And neuropsychologists are among the only professionals that would evaluate their executive functioning. So to formally evaluate how well they hold different pieces of information in mind while performing some kind of an operation, how well they inhibit an automatic response, how well they plan and organize, how well they solve problems, for example. We would also screen their fine motor functioning or sensory motor functioning to find out if there's issues there. And of course, since I'm not an occupational therapist, I always refer, if there are problems, to get a more comprehensive evaluation. But we would be able to assess, at least screen, whether there are problems in that domain. And then, of course, neuropsychologists are psychologists first, so we would make sure we understood an individual's emotional functioning, behavioral functioning, and provide interventions for problems in those domains. Talk a little bit about treatment now. So first I want to say that early intervention is really critically important. So we know that we want to intervene as early as possible in order to help kids when the gap is small and to try to keep it as small as possible. Before 2nd grade, again, their reading skills may not be too delayed, but you want to focus on broader language, phonological awareness, etc., in order to kind of prevent things from getting worse. You really don't want to wait for failure. All of the evidence is saying intervene as early as you can. Intervention should also be one-on-one. It should be individualized to make sure an individual moves forward at their own pace. Or if it's not one-on-one, a very small group with kids who are very similar to one another. You want, if they're all reading at a 1st grade level and they all have kind of 1st grade level phonological awareness, that would be important. Your treatment should involve all of these things we've been talking about. So intervention to specifically and explicitly teach phoneme awareness and to improve their phonological processing, treatment that's specifically targeted to their reading, and fluency training. If you have all 3 components of those, you're doing well. And I've included some programs that are endorsed and do all of those things. And you'll read a lot if you look at various websites about multisensory treatment. And the idea behind multisensory treatment is if you have a deficit in phonological processing, then it would be helpful to use other aspects of their cognitive profile to help them to learn these skills. So you want to use visual and tactile and kinesthetic aspects of their cognitive profile to learn new information, and the more different types of senses you involve, they activate different parts of the brain, and they help individuals discover their own learning style, what works best for them. This kind of approach is, of course, effective for all learners, but particularly effective for dyslexic students who really can't use the primary phonological processing skills. The components of the intervention. We've talked a lot about phonological awareness, and again, you have to explicitly teach rhyming, counting words, clapping syllables, etc. And you have to do this repetitively because it's going to be harder for them to learn. You have to explicitly teach sound symbol association. Even if an individual is 12 or 13, there may be gaps in their knowledge, so it's important to go back and understand very specifically where they are in terms of that knowledge and explicitly instruct on that. It's important to intervene at the syllable level of language. So and that helps kind of a reader when they see a new word, where it breaks down. When it's a long and unfamiliar word, where do you divide it if you understand a little bit more about typical syllables and how they work? And understanding more about morphology in reading, so the smallest unit of meaning, so base words, root words, prefixes, suffixes. If you know those, then again, you can look at a word and visually see some of those things that you've been explicitly trained on. Learning syntax, or the set of principles that dictate the sequence and function of words in a sentence, like grammar, etc. And then semantics, the aspects of language that are concerned with meaning. So explicitly teaching about meaning and semantics will help with comprehension. And finally, fluency. It's very important to remediate fluency. A lot of early intervention studies really focused more on the phonological level of intervention and ignored fluency, and what we found over time is you can teach and ameliorate the phonological deficit, but then they remain slow and inaccurate readers unless you specifically address fluency in your intervention. You have to give lots of practice in order to do that. How do we obtain intervention? I'm going to talk a little bit, very briefly, about response to intervention. So for those folks who don't know what response to intervention is, it's a program that in theory was designed to be a prevention program. So identify struggling readers very early on in kindergarten, ideally, first grade, and give a little bit of extra help and see how they respond to that help. And then if they don't respond, give a little bit more extra help. Again, just give additional instruction for these kids and hopefully help them catch up or maintain a smaller gap than you would have if you didn't get that extra help. So in theory, that's really, really great. But the problem is the intervention that folks were getting wasn't consistent, and not everybody was getting the same quality. And there are also really bright, struggling readers who don't look like they're too far behind, and so they're not getting identified. And additionally, with the folks who are very, very severely impacted by dyslexia, we had to wait for them to fail a series of times before doing more comprehensive testing. So RTI is fairly controversial for that reason. So what people like more is to identify individuals who have some of the risk factors for dyslexia and do a comprehensive evaluation earlier. So you have a team of folks in school who you might have an educational person, a special ed person, a psychologist, speech and language pathologist, occupational therapist, whoever needs to be involved, who each do an evaluation. Everybody comes together, identifies areas of weakness, and form an IEP for the child. So an IEP is a legal document that provides both interventions and accommodations. And so ideally, assuming the interventions are dyslexia specific and appropriate, this is really the best way to get the extra help that a child needs. And I should note that just retaining a child really isn't recommended. Doing the same thing, again, is not necessarily the way to go. An individual who has dyslexia really needs a specific kind of teaching rather than more of the same. There's also a number of accommodations that are appropriate for individuals with dyslexia, things like extended time, having a quiet area, help with note-taking, modifying assignments, allowing for kind of oral presentations, etc., listening to books, really trying to reduce or eliminate oral reading in class because it's embarrassing for kids, not penalizing for spelling errors, grade on the content of the material, giving oral exams, reducing spelling tests. Bright individuals with dyslexia are memorizing spelling words without really retaining them. So they can memorize them for the test, but the next time they go to spell the word, it's not there. Allowing technology aids, teaching students to use logic rather than rote memorization. And then as an older student, having a language waiver. Again, we talked about how foreign language is so difficult for folks, so allowing them to substitute a different kind of language, like sign language, or a cultural class to teach about a foreign culture. Having college students major in a course of study that's an area of strength for them, getting notes in advance, if in college only taking one class at a time or two classes at a time, previewing their reading, potentially with a tutor, using speech-to-text programs for writing, those are all very helpful. Just a very quick note about treatments that are not so helpful. So there's a lot of misinformation about dyslexia out there. It's important to avoid exaggerated claims or false guarantees. So there's, people that say, we'll cure your dyslexia in 8 weeks. Well, that's impossible. We know that's not the case. There are approaches that say there's a single cure and we can cure it, and that's not true. It's a really complex neurodevelopmental disorder, as we've talked about, so there's no single cure for dyslexia. And if a program doesn't specifically target reading, that would be a red flag in my mind. There's also programs that will teach a specific skill, and if you test them before and after, kids have learned that skill, but they don't translate to long-term gains. And then if it's not supported by independent science, if it's just from that one particular group, that's important to pay attention to. Very briefly on long-term outcomes, in the long run, the outcome will be different for each person, and it depends on a lot of factors. For example, it depends on how severe their condition was to begin with. It depends on how effective the instruction or remediation they get. And it depends on comorbid conditions and whether those are treated or not. So, there's lots of different factors that would play into a long-term outcome. We also know that some individuals compensate for their difficulties early on, but have these lasting deficits that stay with them, or difficulties that really emerge later in their development. But we do know that without any intervention at all, there's a downward trend over time. Folks have difficulty acquiring new knowledge because they're not reading. They maintain poor spelling and writing skills, and they aren't able to express their knowledge well. Again, they're laborious and slow readers. They're inconsistent in their schoolwork. They feel they're dumb, which leads to underachievement. But with appropriate intervention, individuals can overcome or adapt these difficulties and maintain a positive self-image and self-esteem. We know from research that if they receive intervention in kindergarten and first grade, there's significantly fewer problems overall in the long run. But it's really important, like I said, to give reading-specific, dyslexia-specific instruction, even for older students, because it's really never too late. You can still remediate some of those basic issues. With appropriate intervention, we know that kids become successful students in college and successful in life, particularly when they have these other areas of strength that if we have the right type of intervention, we've identified and can work with them over time. It's just very briefly in the job, we know that individuals with dyslexia can have difficulty with aspects of training, and they're eligible for accommodations. you're protected under the American with Disabilities Act. So you should request accommodations if they are necessary, such as, you know, assistive technology or extra time on things, etc. I've included a slide with resources for additional information, and now I'll take questions.
Okay, it took me just a moment to unmute myself there. Okay, we have quite a few questions, so I'm just going to launch in right away. Okay, that was a really wonderful presentation, Doctor. Thank you.
Thank you.
So, I have a question about assistive technology. I know you touched on it a little bit, but someone posed a specific question about a particular type of assistive technology. So I'm just going to pose that, and maybe you could broaden that whole topic just a little. The question was specifically about EDMARK, E-D-M-A-R-K. Are you familiar with it, and in particular, and if you could put a little bit more information about assistive technology for us?
Sure. You know, I have to say that as a neuropsychologist, my expertise is in identifying dyslexia and less so kind of in the treatment realm. So I'm not directly familiar with EDMARK, so I can't really comment on that. But there are a number of different programs that can be very, very helpful. Dragon, naturally speaking, is one voice-to-text program that allows folks to read, and then it, you know, to dictate their thoughts, and then that helps, and then it writes it, and so they can dictate rather than write or type.
Yes.
And that can be really helpful. You know, that's one that is very common. There's there's lots of information on assistive technology and on the IDA website and some of those other resources that I gave. But I'm really not an expert in
That's absolutely fine. And actually, now that I'm just thinking about it, we did a webinar a while ago. I want to say in the spring of this year or late last year, that had to do with exactly that topic, and I'd kind of forgotten it until you mentioned Dragon, but that would be, I would certainly direct the person who asked that question to go to the webinar archive and listen to that. It mentioned Dragon along with a number of products out there that are really good. What are nonsense words?
Nonsense words are made-up words, like nib, ack.
I'm sorry, you broke up right then. Like what?
Like nib, M-I-B, or ack, or verlugagendiplo. Things that are supposed to sound like real words but are not real words.
Okay.
So sounding that out will test whether you have really mastered the letter sound correspondence rules. If you go to sound out the word nib, M-I-B, you have to know M says I says I, and B says B. So that, you know, that at that very basic level, you can, a lot of people with dyslexia misread even that simple word. They might say MIB because they don't remember that the E makes the I say its name, you know, those kinds of rules.
Okay. All right. I have a question, and I've had to consolidate this a little bit, so I'll try and break it down. But so we have a mom asking this question. She has a student in the 11th grade, and the student has an IEP based on what was defined as a listening comprehension. That's the disability that's stated on the IEP. So what the IEP provides for are audio books and textbooks. So recently, this student has been diagnosed with dyslexia. Now she's the student's in the 11th grade now. So the mom is not clear on how audiobooks will help if she has a problem with listening comprehension. And I understand we're not asking you to diagnose anything here, but we're interested in your comments on that.
Well, I actually agree with her. If you have a problem with listening comprehension, not reading comprehension, it's listening comprehension, then books on on, audiobooks are not necessarily going to solve that problem for you. If the problem is reading comprehension, then hearing it spoken aloud, especially if you're following along yourself, can be very, very helpful. So for dyslexia, audiobooks are great. For a listening comprehension problem, that's not necessarily going to solve the problem.
Okay, it makes you wonder if maybe the student was misdiagnosed.
It does make you wonder that, or if there's broader language issues or potentially attentional issues, that are, are factoring in as well.
Yeah. All right, I have a question from an educator that has to do with the connection with something you said about who can diagnose a child with dyslexia, and it doesn't need to be a neurologist or a neuropsychologist and so forth. But apparently, in some situations, there are rules within a school district that say that they can only be diagnosed by either one of those doctoral professions. So, based on your presentation, does that sound to you like it's potentially a rule of the district and not necessarily a rule of who can make the diagnosis in the real world?
As far as I know, that's exactly right. I think it's a district-specific or potentially a state-specific. I think there are probably certain states that identify, but probably it's a district level. But what we know, about diagnosing dyslexia is if you have dyslexia-specific training from, and the International Dyslexia Association website will give you a lot of information on even how to get that training. But if you're trained in the Orton-Gillingham approach, then in the broader world of dyslexia, you're considered an expert and can make that diagnosis.
Okay. I'm trying to find it here in the list. Just bear with me a second. We've got so many questions that are flying in now. How do you identify dyslexia in a student whose primary language is not English?
Well, that is can be very challenging, actually. Ideally, you'd have someone, a neuropsychologist or an educational expert in dyslexia who also speaks that child's language and can use the child's primary language and can use materials that are specific to that child's primary language. So there's a lot of these materials, these assessment materials that have been translated into Spanish, for example, and other languages around the world. So, those materials are out there. It's harder to find an individual who's qualified to do that. If an individual is fairly equally skilled in both languages, meaning maybe Spanish was their primary language, but they've been educated in English, and if you test them, their test scores are fairly similar in both languages, then it's considered okay to base your diagnosis based on their English-based test results. But if it's not kind of a Spanish language question, and if it's a question of a language that's quite different, that is a harder diagnosis to make because dyslexia actually looks different across different languages. It's very interesting. There's lots of cross-cultural research on dyslexia and how it looks and how it translates. For example, in a language that doesn't have a phonologically based alphabet, you cannot look dyslexic in that language, whereas if you're tested in English, you do look dyslexic. So it looks different across languages.
Okay, sounds very tricky. Would you talk about the youngest age and level of accuracy for assessments used in the diagnosis of dyslexia?
The comprehensive test of phonological processing goes down to age 4. So you can give a test to understand an individual's emerging phonological abilities down to that age. And I would say that would give you a lot of information. If they're really struggling at that age with phonological processing, that puts them at great risk. But I wouldn't definitively diagnose dyslexia earlier than that. I would say watch this over time, come back when the child is a little bit older, and let's see where they are.
Okay. For a 14-year-old with dyslexia, is it better to read out loud or to oneself?
It depends on the child. I test a lot of kids for, if I ask them to read silently to themselves, they're not going to do it. And then and asking them comprehension questions doesn't really work because they haven't actually read it. So if a child is actually going to laboriously get through the material, then they can read silently to themselves if, you know, if that's the child that you have. But if you have a child that's not going to do that, it's better to read out loud. Additionally, you know, if you're going to read out loud, a parent can be sitting with you and can coach you on different words and can talk through the material, a parent or a tutor, I should say. So reading out loud gives you know, a lot more information and a lot more opportunity for correction.
Okay, well that makes sense, I guess. So along that same line, I'll go with a 14-year-old. How long should a student with dyslexia need to read in one night? Like
how long?
How long? How much time? Yeah, that's really the question. So should it be an hour? Like, does this student that's kind of struggling with this, do they need to spend an hour doing it? Do they need to spend 30 minutes? You know, do you have any sense about that?
I don't know that I can specifically say that, but what we do know from research is the more you practice, the better you're going to get. So the more they read, the better they're going to get. But you have to weigh other factors. I mean, if a child is really struggling and needs a break after a while, then, you know, more is not better in that case. Or if it's really getting them down at how difficult how difficult the reading is, then give them a break. I mean, I don't know that I can say 30 minutes or an hour is better. I think that also depends on the individual.
Okay. What do you think of a situation where the child and the parent are working together? So the child reads a page, let's say, and then the parent reads the next page, so that there's an opportunity for the child to get a break, and then there's a discussion maybe about in terms of the comprehension,
Right.
as far as what did the child get out of what they read and what the parent read.
Right. Yeah, that's a great way of doing it. And a lot of books are actually designed that way, so they have a page for the parents and a page for the kids. There's a whole series of books like that. And that's a great way of doing it.
Okay, and I think we're going to have to wrap it up here because we've gone quite a bit over, and I want to thank you for a really great presentation. I'm going to pass it over to Kelly for a wrap-up.
Thank you for joining us on our webinar. There is an exit survey which we need everyone attending to fill out. The webinar blog is now open now and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to our website. Our next presentation, The Life Cycle of Tics, will be presented by Dr. Michael Rubenstein and is scheduled for September 26, 2016. This ends tonight's webinar. Thank you, Dr. Humm, for your presentation, and thank you everyone for attending. Good night.